My patient is a 20-year-old female. Her name is Nicole, and she went into the clinic for a chief complaint of blurring of vision at distance and near. This is often associated with headache, especially after reading. And eventually, after a prolonged reading, there is some form of difficulty concentrating on the near tasks. Especially the patient is a student, she is having a hard time concentrating or studying for prolonged period. By prolonged period, I mean it's around 1 hour or beyond 1 hour, more than 1 hour. Now, there's an onset of the symptoms of the patient which is gradual over the past years. But she feels there is a worsening, of her symptoms during the current school year or this year. The duration of the complaint is persistent with increased severity during periods of prolonged reading or screen use. Aside from the frequent headaches, the location is located around the forehead. The patient also complains of eye strain, especially again after studying. So prolonged studying for more than 20 to 30 minutes, or beyond 1 hour, the patient experiences the symptoms. There is also some occasional doubling of vision at near, which often occurs, especially later in the day. The patient reported needing to hold a reading material a bit farther away to see clearly. So although this complaint is not often, but there are instances or times that the patient may experience such. Under medical history, there is no significant or systemic illnesses, which often occurs, especially later in the day. The patient reported needing to hold a reading material a bit farther away to see clearly. So although this complaint is not often, but there are instances or times that the patient may experience such. Under medical history, there is no significant or systemic illnesses or no history of trauma. During the ocular history of the patient is a eyeglass wearer, of last year, and no history of any eye surgery. The patient is a myopic, with a correction of -1 diopter sphere for both eyes. The correction was last year, January 2024. Both family ocular history, the mother has history of myopia, while the father is emetropia. Other social history, the patient is using a screen time for approximately 10 to 12 hours. Interchange use of phones, laptop, for schoolwork, and sometimes for leisure purposes. No sports activity, mostly the patient has sedentary lifestyle. Under preliminary examination, visual acuity presents unaided visual acuity presents distance UVA for OD or right eye of 20/60 and left eye of 20/60. For near visual acuity, both eyes presents near VA of 16/40. Pupillary reflexes presents normal or equally round and reactive to light +1 and accommodation +2. Extraocular muscle or EOM movements are full, smooth, and there are no restrictions. Both cover tests for distance and near. For distance presents orthophoria, while for near there is a slight exophoria. And under NPC, near point of convergence, the patient has recording of 10 over 14. The break over 14, 10/14 centimeter. Stereo acuity test using a Randot stereo test reveals a 60 seconds of an arc, which is a bit reduced from the normal stereo acuity findings or result. Under internal examination, all the anterior segment, posterior segment reveals no significant finding. Some notable information or recordings such as optic nerve head, a CD ratio of 0.3 was noticed. Both macula and peripheral retina presents within normal limits of findings. Now let's go to the objective refraction. Uh, we perform autorefractometer. Okay, objective refraction or retinoscopy reveals a test of OD minus 150 and OS minus 125. No significant astigmatism was noticed. Under subjective refraction, findings of your objective refraction was placed and asked the patient to read the chart revealing a correction for OD of minus 150 with a visual acuity of 20/20. OS reveals minus 125 diopter sphere with a visual acuity of 20/20. Binocular balance was presented and balanced at endpoint using a prism dissociation technique test. Binocular vision testing presents amplitude of accommodation using a push-up method for the age of the patient, which is approximately around 10 diopters, reveals a AOA of around 7 diopters for both right and left eye, which is a bit of a reduced result than the normal findings. Accommodative in facility using plus and minus diopter flipper lens, both monocular and binocular. For monocular, it cannot clear on minus lens easily, so it fails monocular, and then binocular presents a slow clearing both on either plus and minus lenses. And results of the cycles per minute, reveals a recording of less than 10 cycles per minute. Okay, and negative relative of accommodation is normal, plus 2 diopter, and the positive relative of accommodation of minus 1 diopter is most likely abnormal or reduced. A further performed test such as vergence testing using base out, base in prism at near under base out to test for the convergence, there is a reduced recovery of the result. Likewise, for base in prism, divergence test that reveals a normal function. Based on the test that I have presented, I will come up with a diagnosis of a possible myopia or low-grade myopia for OD of minus 1 and OS of minus 125, associated with some binocular anomalies, which is accommodative insufficiency. Management for the patient will be a full optical correction, which will be prescribed full-time wear of single vision spectacle, OD for minus 1 diopter sphere, OS for minus 125 diopter sphere. And I may recommend a vision therapy for accommodative insufficiency. By the way, the condition of the patient for myopia is a common condition, especially for the age range of the patient. But for most of the examination, it is often unlikely notice or observe the presence of accommodative insufficiency. So with that, since I would suggest for the patient to underwent some home therapy program. So we can do the vision therapy into home therapy program and office-based vision therapy. Under home therapy program, we will instruct the patient to perform pencil push-ups 5 minutes 3 times daily. So it depends on the availability of the time of the patient, but we would recommend 1 in the morning, 1 in the afternoon, and 1 in the evening. Heart chart distance or near rock is also recommended. And we will give the patient accommodative flipper lens exercises of plus and minus 2 diopter sphere. As for office-based vision therapy, especially if the symptoms persist after 4 to 6 weeks, we would suggest the following: monocular accommodative amplitude and facility training. Binocular accommodative facility training. This can be using a heart chart or using a flipper lens technique. Vergence therapy if near exophoria becomes symptomatic. Otherwise, if the patient will not have will improve his condition, so no need to perform for the vergence therapy. Additional management for the patients is also to consider some ergonomic and behavioral modifications. So first things first, there should be We should implement the 20-20-20 rule, which means every 20 minutes the patient will take 20-second break and look at 20 feet away. Limit the prolonged screen time, especially without breaks, and then proper lightening and posture during reading and computer use. Follow up for the office and home vision therapy after 6 weeks. Reassess for accommodative amplitude and accommodative facility. Also monitor the symptoms if there will be some reduction or some improvements. After 6 months, the patient may come back again for another comprehensive eye examination. Check for the progression of myopia and may release binocular vision status after 6 months. That's all. Thank you.